We're going to have a presentation tonight on the anterior hip replacement, everything you want to know about hip replacements, anterior hip replacements, but we're afraid to ask. First of all, I'd like to thank the Gilded Institute for supporting this presentation and other presentations that we have at Sibley Hospital. My name is Dr. Unger. As you can see from the slides, we have about a 20-minute slide presentation. And during the presentation, you're welcome to use the Q&A part of the Zoom presentation. Type in your questions, and I'll try to answer those questions after I'm done with the slide presentation. I'll try to go through as many questions as possible. We can't have any interactive sort of voice discussion at this point in time. I also want to tell you that if you need to contact me after this presentation, my email is dr.unger, U-N-G-E-R, at wasm, W-O-S-M.com. You won't get any clinical information from that, but if you have any questions, my assistants can help you with that. So we're going to talk about the anterior hip replacement, rapid recovery for joint replacement surgery. So the Gilded Institute is an orthopedic institute at the Sibley Hospital that encompasses the area of joint replacement. Hip replacement, knee replacement, shoulder replacements. This is a team approach that involves orthopedic surgeons. We have nurse navigators, have a program coordinator, and we coordinate with internists, family doctors, cardiologists, anesthesia, and we have a dedicated orthopedic unit at our hospital. The hospital is located at the Sibley Hospital. It's part of the Johns Hopkins Medicine Center. It's part of the Johns Hopkins Medicine program. Tonight's seminar is going to be talking about hip replacements, particularly the anterior hip replacements, and new techniques for total joint replacement. So who am I? I'm an orthopedic surgeon, board certified orthopedic surgeon. I'm the director of the Gilded Institute of Bone and Joint Health at Sibley Hospital. I'm a member of the Washington Orthopedic group. It's called WASM, or Washington Orthopedic and Sports Medicine Group. We're a 12-man group, or 12-person group with multi-specialties. A charter member of the ACUS group, which is the American Orthopedic Hip and Knee Replacement Surgeons. I'm a professor of orthopedic surgery at GW as well as Hopkins, and I've had 35 years of experience in joint replacement surgery, primarily doing 10,000 plus hip and knee replacements, specializing in this and writing about it for years and years and years. To begin with, I want to talk a little bit about what a damaged joint is and why somebody might need something called a hip replacement. Joints have articular cartilage, which is the surface of the joint, and when you lose that cartilage, you essentially have arthritis, and this causes pain, loss of motion, stiffness, and inflammation, which you perceive as pain. On the left-hand side of the screen, I'll use this pointer, is a healthy joint. This is a knee, and you can see that this is a knee joint. The top is the femur bone, the bottom is the tibial bone, and the cartilage is the surface that you walk on, okay? This is about a 5 to 6 millimeter surface. It's a creamy colored tissue. It works essentially like ice on a piece of concrete, and there's two surfaces on either side. When you lose the cartilage, and you can see on the right-hand side that the cartilage erodes away, the bone is exposed, they grind together, causing stiffness and pain. Unfortunately, there's no regeneration of articular cartilage that's available today. People are working on it. It's far, far in the future. I don't think you should wait, 6 months because we're going to have regeneration of articular cartilage next year. I don't see this coming around for patients for maybe a decade or more, probably much more than that. So today, the only thing we have is essentially putting a new surface on, which is what a joint replacement is. Now, arthritis is very common. There are many different kinds of it, probably 100 different types, most commonly being osteoarthritis and rheumatoid arthritis. It affects 40 million people or more, probably more than that. Many people get it. 1 in 7 people have the problem. It affects all ages. And obviously, after 45, it's much more common. Once you got it, you can't get rid of it. And women, unfortunately, have it more commonly than men. We're going to talk specifically tonight about hip replacement surgery. And hip replacement surgery is a very, very, very commonly performed procedure. It was sort of perfected in the 60s. It's been around for 60 to 70 years. It's really a wonderful operation, probably the best operation that surgeons have in general. It consists of essentially implanting an implant. This is a cartoon of the surgical implant. It consists of two pieces. One is called the shell. The shell is a titanium-based piece of metal that is either cemented into the bone or pressed into the bone where the bone grows onto it. This is called the stem, which is pushed into the thigh bone. So this is the pelvic bone up here, the thigh bone's down here. And this piece is either titanium or a metal called chrome cobalt. It's most of the time it's pressed into the bone where the bone can grow onto it. Occasionally it's cemented in as well. And then the bearing, which is up in here, is usually today either a metal or a ceramic head that rides up or rubs up against a piece of plastic. That's the most common, what we call bearing. These things last an incredible amount of time. Typically, years ago, 15 to 20 years, probably now 25 to 30 years with good care of it. So again, as I said before, hip replacement is the most effective surgical procedure of the 21st century, and that's been shown from a perspective of patient satisfaction as well as what we call orthoeconomics, which means, in other words, if you get your hip replacement, what's the most effective way of getting you walking again, exercising again, getting healthy again? And the surgical procedure has been time proven to be effective with little complications, great outcomes, and now we have implants that are very what we call durable, which means that they last, as I said before, 20 or 30 years or even beyond that. Question for the patients is obviously, how can I get through this with less pain and a faster recovery if it doesn't compromise outcomes? And this is where the anterior hip replacement, I think, has come into play. That you can get this operation with less pain, faster recovery, and still not compromise the long-term durability of the implant, as well as complications are not any higher than any other surgical procedure. And that's the minimal invasive anterior hip replacement. And I have to say, Sibley Hospital has been sort of the center of this for at least the last 10 or 15 years. It involves multimodal pain control, what we call the ERAS program, and modern anesthesia techniques that allow these procedures to be done with at most the overnight stay and sometimes as an outpatient. It involves a small incision in front of your hip, not cutting any muscles or tendons. The old way was cutting through muscles and tendons. We've eliminated that. We can use x-rays or imaging or even computer guidance to help visualize the implant position. There's little postoperative restrictions, and the patients recover very quickly. Some patients are going back to work in a week, sometimes 2 weeks, sometimes 4 weeks, but I would say some of the younger patients are doing this as an outpatient and going back to work within a week or so. This anterior hip replacement, and I think we should really stress this, is not new in terms of its surgical approach. So we didn't invent this in the last 15 years. This has been a procedure, this is from the German literature, note the date, 1883. This is Dr. Heuter, who used this approach to, at that time he wasn't treating arthritis, he was treating infections, but this surgical approach has been around in the orthopedic literature for way over 100 years. So it's not new, it's just orthopedic surgeons have been using it for the last 15 to 20 years for hip replacement surgery and have had great success. The advantages of the anterior hip replacement is we can pretty much get your leg lengths back to the proper length. We have good stability, which allows you to walk quicker, do things quicker, less muscle damage, and faster recovery. Now, always the question that comes up in my office is whether we should use a specialized table. And I put a regular table in here, but the specialized table is a very complex piece of equipment. Nothing wrong with it, but I think we should point out to the audience, if there's any questions that come up, is that the table is only a piece of equipment. It doesn't really do the procedure. The table is only an accessory piece of equipment, and it doesn't allow for any better outcomes, any less complications, any less precision than any other way of doing it. I happen to do the procedure without a specialized table. That's just because I was taught how to do this procedure without a specialized table. But I don't want any of the audience to sort of seek out, orthopedic surgeons because they heard the surgeon has a table and he's the only one in town who can do this operation with the table. That's not the case. Half the surgeons in the world who do anterior hip replacements do it with the table, half do without. There's no difference in the outcomes. And that's a very important point. Now, as I said before, Sibley Hospital and our Gilded Institute has been at the forefront of anterior hip replacement surgery. We published this paper back in 2011. We've subsequently done many other papers in regards to anterior hip replacement. And this was a comparison of the regular hip replacement, which is called the posterior approach, to the anterior approach, looking at what we call inflammatory markers, which is signs of muscle damage or invasiveness. So this was an attempt, and really the first attempt in the orthopedic literature, to look at whether the anterior approach was a better approach in terms of causing less muscle damage. And what we found, you can see in this paper, and it was published in this article, in this journal called the Journal of Bone and Joint Surgery, which is a very prestigious journal, that when you look at, this is an enzyme called creatinine kinase, which measures muscle damage, and we looked at it, and the blue is the DA, the anterior approach, and the gray is the posterior approach. Significant differences. Where you see dots, that means differences statistically. So we found in the immediate period, 1 day period, and a 2 day period, and cumulative data, that there was much less muscle damage with the anterior approach as compared to the posterior approach. And this has been done, several centers have done this. The Mayo Clinic has replicated this data, and we were the first in the world actually to do this. So how do you get this through this procedure? Anesthesia is important. We're doing mostly spinal anesthesia today. The ERAS protocol is a protocol which involves using multimodal anesthesia. We don't like narcotics. We like to give non-narcotic medications, rapid mobilization with physical therapy, and we can get these procedures done so you can leave the hospital within a day. Leads to a quicker recovery, better pain control. Most of our patients are not taking narcotics. They're usually taking Tylenol, Advil, Celebrex occasionally, Tramadol, very rarely taking narcotics. Less blood loss and better outcomes. So the patients are recovering faster, getting back to where they want to go faster. And at the end of the day, they have a hip that's going to be a hip that's going to last them, hopefully 30, 40 years with good function. So how do we do the multimodal anesthesia, the so-called ERAS protocol? We give oral medications before surgery that reduce pain and swelling. These are medications like Celebrex, which is a very good medication if you can take it. Sometimes we use some steroid medications that are given intravenously, and other medicines that can reduce pain without causing the complications that we get from narcotics. So we're very careful not to use, we have to use some narcotics, but we try to reduce the narcotic consumption tremendously. We actually have shown that our new protocols reduce the narcotic consumption significantly. We also very much are using what we call local injections into and around the hip and the knee at the conclusion of surgical procedure. So the surgeon will take local anesthetic, long-acting local anesthetic, and make multiple injections in and around the joint so that patients can get up and walk on it. And most patients are walking on their joints the day of surgery. That's the medicine that we use, ropivacaine, which is a long-acting anesthetic. There are other ones that we use as well. We're using some morphine mixed in with that, as well as this medication, which is an anti-inflammatory medicine. So patients generally require only a couple doses of oral narcotics. Most patients are not using any narcotics after that. We use Tramadol, which is a painkiller. It's sort of a pseudo-narcotic, and Tylenol, and Motrin, and Celebrex, and that helps these patients get up and mobilize very quickly. So as I said before, the younger patients, and some are even the older patients, can go home the same day if they're in good shape physically. Spinal is given to the patients. The operations usually last about an hour. That's the typical procedure time that it requires for our procedures. So patients in the morning can get up and walk with physical therapy in our unit, and then go home that afternoon. And again, those are healthy people, generally younger patients. Older patients sometimes are required to stay overnight. Almost none of our patients are going to rehab centers. The amount of physical therapy that we're finding that patients need is very minimal after these procedures. Usually our physical therapists work with you in the hospital a couple of times. 1 or 2 visits, getting up and down the stairs, showing you how to get in and out of the bathroom, mobilize yourself in terms of walking up and down the stairs with and without a walker or crutches. Then when you go home, our protocol is to send a physical therapist to the house a couple of times, usually 2 or 3 times at the very most. And then most of my patients don't need physical therapy after that. Occasionally at 4 to 6 weeks, they'll get some physical therapy. But we've shown actually, and several other centers have shown, that physical therapy is really not critical to the recovery of this operation, that most people recover very nicely without the physical therapist. So we do encourage one preoperative visit. That's called a prehab visit. And that visit is done through our office. My physician assistant will arrange that, where a physical therapist comes to the house and goes over exercises and then looks at your environment and makes some suggestions about getting that rickety chair out, maybe that throw rug that needs to go in the closet. 1 or 2 sessions in the hospital with the hospital physical therapist, 3 or 4 sessions with the home physical therapist. And then occasionally people at 6 weeks will get some home physical therapy for a couple of weeks afterwards, but less and less of that as time goes on. Actually, in some respects, COVID has created an environment where patients don't want to see the physical therapist. So, and they're doing fine without the physical therapist coming to their house. Well, everybody wants to know, what can they do with their new hip? What are they allowed to do? Particularly the younger patients are interested in this. And let me say that I pretty much let them do almost everything. If you look at this list here, they can walk, they can hike, they can swim, they can play tennis, they can play golf, aerobics, fitness. I let them ski, as long as they don't do black diamond skiing and jump off of cliffs. Biking. The only thing we don't want you to do is to go running. And everybody probably does a little bit of running. If you run, it's not like your hip's going to fall apart. But if you sign up for long runs, marathons, you're going to wear out your hip, and you're not going to get the 15 to 20 year period of time that we want you, or actually longer, 30 to 40 years of time that we want this hip to last you. So how long will a hip last? If you take good care of it, probably 25 years in most circumstances, probably more than that. The newer generation of plastic that was changed about 15 years ago is showing data that's probably giving us a good sense that these are going to last 25, 30 years and beyond. Again, individual circumstances differ. There are different weights of patients, different activity levels. We can't guarantee this at all, but it looks as though the data looks very good for a long-lasting joint replacement, even for younger patients. So I'd like to thank you for my presentation, and now I'm going to go to the Q&A, which we just have one at this point in time. If anybody else has any questions, please feel free. And this is a question from Allison Brooks, and it's a good question. It says, do people have allergies to surgical cement used in to secure the replacement in place, the way they have allergies to cement used in closed incisions? And the answer to that is, I do not believe there has ever been any literature to suggest that there are allergies to surgical cement. Surgical cement is used very infrequently today in orthopedic cases, in hip replacement cases. Probably only 10 or 15% of the cases we do are cemented into place, but there's really never been any allergies that I have seen or have noted in the literature to bone cement. So this has not been a problem. Bone cement, the only problem with bone cement is that bone cement will break down over time. So most cemented joint replacements will not be a 30 or 40 year joint replacement. So we tend to use these in older patients who are what we call osteoporotic, which means their bone is weak. So we'll cement those because we're concerned that their bone may be too weak to be what we call uncemented. So those implants will be cemented. Here's another question from Howard. How long do you need to wait between a hip and knee replacement on the same side? This is a very good question, okay? So I would say the minimum would be 6 weeks. The usual period of time would be 3 months. And here are the two issues with the hip and knee on one side. Number one, you do your hip first, your knee is done second, and that's because of alignment issues. And The hip should be done first. There's usually some swelling of the hip afterwards and the whole leg for several weeks, if not a month or so afterwards. So it's probably not a good idea to have your knee operated on when it's swollen. The other issue with doing your hip first and then doing your knee is that to do the knee, we have to twist and turn your hip, and we don't want to pop your hip out after surgery. So most of the time, it's going to be, let's wait a little bit, let's let things calm down. The last issue with hip and knee replacements on the same side is the issue of blood clots. Now, blood clots are very, 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 very rare with hip and knee replacement surgery, but when you insult the hip and knee twice in a short period of time, you may increase the likelihood of getting a blood clot. So I would prefer in most of my patients to probably wait 3 months. Okay, we're getting lots of questions now, so we have to move ahead. Personal question. I'm a Kaiser Permanente. Is there any vehicle way for you to do my? And the answer is, of course, yes. I do Kaiser. The question is, if I'm a Kaiser Permanente member, can you come and see me in the office? And the answer is yes, if you have out-of-network benefits. So Kaiser Permanente, as you know, is a HMO. So if you're locked into their network, you're going to have to work with their physicians. If you have out-of-network benefits, you can come and see me, and it's just like any other patient, that would not be a problem. Here's another question from Ronald. Do you recommend surgeons who are trained more recently and learned the procedure in fellowship versus more senior surgeons? Very good question. Okay, so I'm a senior surgeon, so I'm going to defend the senior surgeons, and here's what I would say about that. Surgeons that have a lot of experience are very, very, very worthwhile to go to. A surgeon who has maybe done this, I think the critical question should be, how many times have you done this procedure? A surgeon who is, maybe just came out of fellowship or residency and learned to do this procedure in residency, did it maybe, there, would probably be somebody I would not necessarily go to at the first, at the beginning. I'd let that person get a little bit more seasoning before I would have him do my hip or knee replacement. Somebody who's been around for a while and has done this procedure a number of times and specializes in this procedure is somebody I would probably work with. This is a procedure, I must say, that is technically difficult, and it's not for everybody, and I think most of the people who do this procedure specialize in this procedure. Fortunately, at our hospital, there are several surgeons who exclusively do this procedure and are trained in this procedure. So I'm not the only surgeon in Washington who can do this procedure. There are many, many good surgeons in Washington who are trained in this procedure, who have done it for many years and are very good at doing it. So let's see. Here's another one. Here's a very good question from an anonymous attendee. How soon after hip replacement can you climb stairs? And the answer to that is right away. You will not be able to leave the hospital unless you can go up and down the stairs. So if you have stairs at home, don't worry about coming to the hospital and having your hip replaced, because after surgery, our physical therapists will make you go up and down the stairs. And if you can't go up and down the stairs, they will keep you in the hospital so you can go up and down the stairs. Almost everybody can go up and down the stairs immediately. So that's not an issue after a hip replacement, whether you have it as an outpatient or you have it in the hospital. Hope that answered that question. Let's see if we have any more questions. Okay, oh, great. Are hip revisions involving worn plastic socket linings usual after 13 years from the initial operation? Why does this occur? Must it be replaced, and will it not occur again? Very good question. So the question is about a revision surgery for a plastic socket that's worn out. Okay, so hip replacements done 13, 14, 15 years ago were done in an era in which the plastic is not the same plastic that we're using today. And those plastics have worn out after 10 or 15 years. And the answer to that is that not every plastic that's worn out needs to be revised, but most do. And the reason for that is when plastic wears out, it creates debris. And these are little particles that get loose in the joint and sometimes cause two issues. One is they will cause irritation of the hip. So patients will come in complaining of pain. And the second thing is that the little particles from the plastic will cause what we call bone loss, and that's called osteolysis. So those two issues, if a surgeon like myself sees those with a patient, we will encourage patients to have surgery sooner rather than later. The third issue with wear of the plastic is occasionally plastic will wear out and cause the hip to pop out. And of course, that's a reason to go ahead and have surgery. If those circumstances have not occurred, if the patient is not having pain, if there's not osteolysis, and if the hip has not popped out, it could be observed for a while and watched. But again, it depends upon the patient's age. If somebody has a lot of plastic wear and they're 75 years old or 70 years old and they're in good shape physically, it's probably best to address it earlier rather than later. So the second question is, will it happen again? Nobody knows for sure, but the newer generations of plastic are not showing the wear rates that the older plastics had. So I would say a revision surgery with the newer plastic would probably not result in a third operation. Please provide your contact information. This is from Jeanette, and my contact information is, my email is dr.unger@wasm.com, and it's Washington Orthopedics. So if you just Google Washington Orthopedics, you'll get our phone number, and you can easily contact me or my assistant. Okay, and another question from Inga is, how do you use robotics in your operations? What about custom implants? Okay, so that's a very good question. So the answer is, I am not using robotics in hip replacements at this point in time. There's nothing wrong with robotics, but I've found that I've looked at several robotic platforms, and I've found that robotics have not really enhanced my operative procedures. So I've not utilized robotics at this point in time. I would say to you that there's a possibility in the future robotics may have a role in a hip operation. They're actually more commonly used in knee operations today than hip operations. So we have actually done research on the value of anterior hip replacements done through a non-robotic scenario versus robotic scenario, and found that our accuracy in the non-robotic situations is almost as good, pretty much close to almost statistically the same as a robotic situation, so we've not utilized robotics. Custom implants. Okay, custom implants are, I would say, to be avoided. I've had a lot of experience with custom implants. We went through the generation of gender-specific implants, particularly in the knee, and they've really not shown any benefit at all. So I would tell you that the vast majority of anatomies are dealt with 99% of the implants that are out there, and custom implants have not shown any particular value at this point in time, unless you're dealing with a very specific situation, somebody who has very unusual anatomy, maybe a revision situation. So we are not using custom implants for routine primary cases. Now, revision cases, special scenarios, we'll use a custom implant, but that is a very rare circumstance for a what we call a primary or first time around joint replacement surgery. Okay, let's see if we're any other questions here. I'm not seeing any other questions at this point in time. Anybody have any other questions at all? All right. So I'll just use this last couple of minutes to summarize the world of hip replacement, anterior hip replacement surgery. I'll make a couple of points. The first point is, oh, is that another question? No. The first point is that I think the state of the art of hip replacement surgery is the anterior hip replacement. I think the literature has now sort of demonstrated that. There's been some questions going in the past about whether an anterior was better than a standard hip replacement. I think the literature has been over and over shown better accuracy, quicker recovery, no higher complication rates, and I think that's state of the art. I think that anterior hip replacements, if you're going to consider having a hip, okay, I'll answer that question in a second. So the anterior hip replacements, I think state of the art is anterior hip replacements. I think Sibley Hospital is the place to have your anterior hip replacement, given our experience with this procedure over the years. And I think our institute, the Gilded Institute, is the place to go. So I've got a couple of other questions I want to go through. How long is your waiting list for a revision operation by you? That's from an anonymous attendee. The backup for joint replacements is probably 2 months, something. It depends upon the complexity of the procedure. It's dictated usually by operative time, in other words, getting time in the operating room. So the waiting time for a revision operation could be 6 weeks. It could be as long as 3 months. It depends upon the procedure. We'd have to look at the complexity of the procedure. So Michael has asked, what is the waiting time for revision with you? I think we answered that. Which hospital do you use the operation? So Sibley Hospital is my primary hospital. That's where we do all these operations. Ronald has asked again, how do you align the pelvis and femur during surgery? Very good question. So the alignment is done through X-ray guidance, and it's done through alignment instruments that we use in the operating room. The anterior hip replacement is been shown through a paper that we actually wrote that is a very accurate way of placing the components. And the reason for that is that these operations are done with the patient on their back. And because you're going in through the front of the hip, the patient's on their back. So you or we know exactly what their anatomy looks like, and we know where it lives in space. So it's very accurate. The standard operation is done with your hip on your side, and you can roll on your side from one side to the other. So the tendency for misalignment is much greater with a standard posterior approach than with an anterior approach. So the alignment issues with aligning the components, the femur and the pelvis, is very accurate with the anterior approach. And that's why the dislocation rate, the hip popping out with the anterior approach, is probably 1/10 of what it is with the posterior approach. So it's a very, very good way of reducing complications. Everybody asks me, particularly other orthopedic surgeons, why did you do this? Why did you learn to do this? I mean, I've been doing hip replacements for 30 years, and I've been doing anterior hip replacements for 15 years plus. And using new techniques in orthopedics is always stressful for orthopedic surgeons, because we like things to be perfect, but we don't like complications. And why did you? People ask me, surgeons, why did you try to learn how this technique? And the answer is that I really wanted to reduce the dislocation rate, because the posterior approach has a dislocation rate anywhere between 2 and 3%. Now, in big studies, the anterior hip replacement is about 0.3%, 0.5%. I really didn't like getting up in the middle of the night when the patient's called and said, I popped my hip out, can you help me? I really like my sleep. So I was looking for a way to minimize the dislocation rate. And of course, having a faster recovery and better outcomes is a benefit as well. But this was more of a stability issue for me. That was why I decided to embark upon learning how to do this type of procedure and getting good at doing it. So, here's another one. I have to catch up a little bit here. I got 5 minutes. If you need both hips done, how long between surgeries? Okay, ordinarily it's 3 months. It can be as short as 6 weeks. There are some patients who are healthy, who can have both hips done at the same time. So we do both hips at the same time. One hip is done, the other hip is done during one operative procedure, and that's for healthy people, generally people less than 65 years old. But I would say 6 weeks minimum, 3 months is usually what we're looking at. Let's see, did I miss any? No. I think we got it all. Okay. All right. So again, thank you for participating. It's a pleasure to participate in these seminars run by the Gilded Institute. I'm obviously a very proud supporter of our institute. I think we're leading the way in orthopedic surgery in the Washington area. We have great surgeons in spine surgery, hip surgery, knee surgery, sports medicine, foot and ankle surgery. Orthopedic surgery at Sibley Hospital is, as you know, or you may not know, is written up in U.S. News and World Reports and other publications as being the place to go in Washington, D.C. So I want to thank everybody for participating. I don't see any more questions, and we're sort of running up against our time. So I think we're good to go.